Good morning. Welcome, everyone. Thank you for coming in person, online, at our other broadcast location at Lehigh campus. Thank you for coming to Primary Children's Pediatric Grand Rounds. And it's really great to be with you this morning. So today is the Ann O'Neill Shigeoka Memorial Lecture. I'm Miguel Canacle, your pediatric hospitalist and course director. This is the claim credit code for everybody to claim. And I mean everybody, even if you don't need the credits, it really helps us. And then the online questions go in the live chat. And in the auditorium, people can just raise their hand, and we use the overhead mics, and you can just call on them if there's time for questions at the end. This is our broadcast location in Lehigh. And then we do an annual survey. It does help our series and the overall Intermountain CME accreditation. Even if you only went to one event, the whole Grand Rounds the whole year, it's like an overall series evaluation. And you'll get the link in the email. I put it in the chat as well. And then please nominate a safety hero when you see the use of a zero harm technique that prevents harm to patients. And today, our brief safety moment for zero harm is from Dr. Hanna Saltzman. And then after that, Dr. John Bonzak will introduce the lectureship and our speaker as well.
Okay, so we have a safety moment from this week from the rheumatology inpatient service. We have a patient who's a high-risk patient who was admitted in the middle of the night a couple of nights ago, who's on anticoagulation, and the med rec basically had the wrong timing, and so he was scheduled to get another dose of his anticoagulation just a couple hours after he already got his daily dose, and it's a daily medicine. And the nurse came in to give it to him, and it was like 2 a.m., and his dad noticed that among the medications he was getting another dose of anticoagulation, and his dad stopped it. But I think that was a near miss because he could have been at risk for a serious bleeding event.
That was really great, and acknowledging the expertise of the parent as well. Slides up here. All right.
And like, wait, don't tell me this was filmed in front of a real live audience. You guys ever listen to that? Anyway, this is the semi-annual. It's held every 2 years, the Ann Shigeoka lecture, which was funded by a generous gift from John Shigeoka, who is Ann's husband. He passed away a couple of years ago, I think just before the last lecture. Ann was a pioneer, you might say, in the care of immunodeficiency patients here. She worked with Harry Hill, and she advocated very strongly for immunodeficiency care, including helping with bone marrow transplants and providing care in the outpatient setting. She died rather early, I would say, from pancreatic cancer. And when John gave Primary Children's this money, we said it would be great to have a lecture every year on immunologic topics in order to further the interest in immune-mediated diseases, which are in everybody's specialty, I think. Even the surgeons have to deal with them sometimes, with a nod to Dr. Saltzman in the back. So this topic is very timely. It's Dr. Ombrello from the NIH is going to talk about autoinflammatory diseases, which I believe the term was coined in about 2000, wasn't it? So this is after Dr. Shigeoka stopped working, and actually it didn't become a widespread term until maybe another 10 years after that, because it's a fairly rare group of diseases, as you'll find out. Our speaker is Dr. Amanda Ombrello, is a clinical researcher in the inflammatory disease section of the medical genetics branch of the National Genome Research Institute. She received her doctoral degree from St. Louis University, completed internal medicine and pediatrics residency and fellowship in adult and pediatric rheumatology at Cardinal Glennon's Medical Center at St. Louis University. And in 2010, she moved to Bethesda, Maryland in pursuit of further research experience with her husband, Michael, I might add, who is also at the NIH and studies systemic onset GIA. At the National Institutes of Health, she has focused her research in the field of autoinflammation. As an associate research physician, in addition to research, she leads the Inflammatory Disease Section's clinical team, which oversees the care of greater than 2,000 patients with novel and established autoinflammatory diseases. So she's become a great resource for me and for the rest of our team. When we don't know what's going on, we send her a note, and or if we find a rare disease through sequencing, she can usually put us in touch with someone who is studying the disease, which is an important component of taking care of patients with rare diseases. So please welcome Dr. Ombrello to the podium.
Thank you so much for that lovely introduction, and I'm so happy to be here with you guys talking to you today. And I hope that by the end of this, you guys will have some thoughts in your head as what you might see if you ever come across one of these patients. So the title is Autoinflammatory Disease in 2024, Hiding in Plain Sight, because really these diseases are, until you know what they are, you're going to miss them. But once you start seeing them, you'll see them over and over again. I have nothing to disclose. And it is my goal to be able to provide you with the common features of autoinflammatory disease and to encourage increased recognition and potential diagnosis, to give an overview of how to evaluate possible autoinflammatory disease patients with an emphasis on genetic testing, and to highlight certain treatments that are of significant benefit to patients with specific diseases. So here's our little roadmap, because we're going to kind of go all over the place. And we're going to start kind of with some cases, like new clinic patients saying you were going to a clinic and here's what you would see. And then we're going to pause and do an overview of autoinflammatory disease, when to suspect, how to evaluate. And then we're going to take it back to those patients again and go forward. Then we're going to go through the process of identifying and characterizing a new disease, and then taking an already established disease at the end and discovering that there's an autoinflammatory component that had originally been missed when it was described. We have lots of pictures along the way too, so I'll try to describe them as we go along. So you're running a bit late to your clinic, but you have, on your first couple of patients, you have 2 new patients today. And so you're going to go say hi to them both and then step out and kind of regroup. So you go into this first room and you see a couple of very frazzled parents and this kid who looks absolutely fine, kind of climbing the walls, spinning around on the stool. And the mom looks at you and just says, "Doc, my child won't stop getting sick. He is 4 years old and he has had 23 illnesses with fevers, and they are really high. He's been treated for ear infections and strep throat a lot of times with antibiotics, but the fevers keep coming back every single month. His doctor sent him to see an infectious disease doctor, and they said everything looks fine. How can that be? He is sick all the time. He gets sent home from daycare, and my husband and I have to swap staying home from work. He gets dehydrated, and we have to take him to the ER for IV fluids. We can't keep doing this. Can you help us?" And so you say, "Okay, well, hello, it's nice to meet you. I'll be back in just a minute. I got to go say hi to my other patient, but we'll have time to chat." So you take a deep breath and you walk into the next room and you see this 15-year-old girl sitting there ready to establish care. She had been born in Armenia, but moved to the US when she was 7. And she says she's healthy, but records show multiple repeated ER visits over the course of the past 8 years for abdominal pain. Multiple CTs have been negative for an acute abdomen etiology, but she did go under the knife and have an appendectomy for presumed appendicitis. However, the path was normal when it came back. She reports her episodes last 24 to 48 hours and are excruciating, where she prefers to lie curled in a ball. The ER notes report concern that she is drug seeking, but she says she does not take any pain medications regularly, only during these episodes. She also has occasional episodes of chest pain that accompany the abdominal pain, and there's a negative family history, and her baseline laboratory studies that she came with were relatively unremarkable, except the UA showed 1+ protein. All right. So you kind of step out of there, say, "I'll be back." And then you say, "I think I heard this lecture one time on these diseases known as autoinflammatory diseases." And you have to start going into your mental box of filed away stories and to learn, refresh yourself on autoinflammatory diseases. So what are autoinflammatory diseases? These are disorders of the innate immune system. And for those of us who are rheumatologists, this is the much lesser known area of rheumatology. We've all heard about autoimmune diseases, which are disorders of the adaptive immune system, but this is a tiny little corner of rheumatology. These are seemingly unprovoked episodes of very intense inflammation, and it'd be very uncommon to find those high titer autoantibodies or antigen-specific T cells like you see in the autoimmune diseases. And here we have some pictures. The first one is, this is a little 8-year-old girl who has TRAPS, or tumor necrosis factor receptor associated periodic syndrome. And these are her abdominal adhesions. Oh, hold on, let me make it the laser. There we go. There. She had all this abdominal pain, and they did a surgery and found that she had all these abdominal adhesions from her repeated serositis. This is a diffuse enhancement on MRI of a patient who has a disease that's known as Muckle-Wells syndrome, which can cause this aseptic picture. These big knees are of a patient who has a mutation in NLRP3, which can cause a disease called NOMID, neonatal onset multisystem inflammatory disease. And this poor vascular perfusion of the ear is in a patient who has one of my favorite diseases known as the deficiency of adenosine deaminase type 2, or DADA2. And so this list here is by no means exhaustive, but it's going to show that these are some of the diseases I've seen during my time working at the NIH, and it keeps growing and growing and growing. Like Dr. Bonsek said in the introduction, it started about 2.5 decades ago and really has exploded now to where there's a huge list. And I would encourage, if you're interested, going to this website where you can read about more of the autoinflammatory diseases. So here are some pictures, because I think sometimes my words don't do it justice, and so maybe you'll tuck this away if you would see some of these patients someday. What does autoinflammatory disease look like? Well, it is quite varied. This is a forearm of a patient who has an autosomal dominant disease known as PAPA syndrome, pyogenic arthritis with pyoderma gangrenosum, and acne syndrome, and this is his pyoderma gangrenosum lesion. As it's autosomal dominant, this is his brother's back, and you can see the bad scarring cystic acne he's had with some active lesions. This unhappy little peanut here is a little girl who has a disease known as familial cold autoinflammatory syndrome. And she, if she went into, for instance, the cold section of a grocery store, or went into an air-conditioned house from being out in the heat, or a cool movie theater, a couple hours later, she would get a fever and this rash. And this is also an autosomal dominant disease, and I say you can kind of spot these patients if they're not on treatment when they come in, because if they're coming in with their parents or their families, obviously one of their parents has it, and they'll come in with like all these layers of clothes because they've recognized that if they control their body temperature, it can prevent these flares from happening. This down here, these eyes are of a little girl who has TRAPS again. This is periorbital edema. This is the hallmark rash of a patient who has familial Mediterranean fever, which was the very first genetically diagnosed autoinflammatory disease. It's known as erysipeloid erythema. Excuse me, and this is one of the many rashes you can see in an autosomal recessive disease known as mevalonate kinase disease, or hyper IgD syndrome. These modeled legs are of a little boy who has DADA2, and they have this thing called livido racemosa. So these patients, this little boy wound up in a derm clinic first before he was referred to me. There's a lot of oral ulcers in autoinflammatory disease, so this is just an undifferentiated child here who came to us with lots of ulcers. This is also DADA2, looking more like a really bad Raynaud's, and he actually went on to have a partial amputation of this poorly diffused pinky toe. This arthritis, we can see arthritis in a lot of our diseases too. And actually, this is a new, just released in the publication just a couple weeks ago, a disease known as Sharpenia, that for anyone in immunology is part of the Lübeck pathway with Hoyle-1 and HOIP. And this here is this is an MRI of another DADA2 patient who was initially thought to have myositis, and presented with this diffuse myositis fasciitis type of picture, but was found to have mutations in ADA2. So where is one going to encounter autoinflammatory disease? Because some of you may be thinking, okay, not going to see this, not my bag. Well, they can come to primary care, obviously, as you kind of were seeing that in our first two patients. They definitely can present to the emergency room and urgent care when they're having attacks. But then they can really appear, and I hope you'll see this by the end, in a lot of subspecialty clinics, not just rheumatology. In fact, they find us often after they have been to multiple other subspecialty clinics. They get sent to ID because they're thinking there might be an infection, immunology thinking they might have an immune deficiency, hematology to rule out malignancy, dermatology, like I said, because they can have various skin findings, ENT sometimes because they're considering tonsillectomy, orthopedics, lots of CRMO sometimes, and they've gone for joint aspiration washout. Neurology, they may have had a stroke. Ophthalmology, for any number of different reasons, and just about anywhere else. So if you see a patient and you say, okay, I think they might have an autoinflammatory disease, what do you do next? Most importantly is to establish a fever pattern. And the best way to do this is to have the family do a fever diary. You're looking to see what was the age of onset. Was it within infancy? Was it a little later? Sometimes these patients are presenting in adulthood. How frequent are the flares? Are they occurring like clockwork every month? Are they occurring maybe once a year or once or twice a year? Or are they happening kind of all the time? How long do they last? FMF flares last 24 to 72 hours. TRAPS flares can last weeks. Data 2 flares can last months. So you can kind of get some differential breakdown if you start looking at how long they last. How regular are they? Are they like clockwork? The most common periodic fever syndrome in children, known as PFAPA, periodic fever with aphthostomatitis, cervical adenitis, and pharyngitis, occurs almost every month. Parents can say, we plan our vacations when we know they're not going to have a flare. Others have no regularity at all, and you'll see that as we go forward. How high is the fever going and how are they taking it? Are there any prodromal signs and symptoms? And this can be all across the board. Some will say, my kid will not shut up for the 24 hours before they flare. Don't know why. Others will say, oh yeah, we know when they ask for a juicy, greasy cheeseburger that something's going to be happening in the next couple of days. Are there triggers? In adults, that can be, did they stay out too late? Did they drink? And kids, it can be, did they have a birthday party they were supposed to go to? Are they going on vacation? Some of these diseases, the parents are like, we can't have a holiday, we can't have a vacation, we can't even have a birthday party without flaring, because just even the good emotional stress can cause them to go into a flare. And what happens in the interim period? Do they go back to being like 100% normal? Or in some of them, are there lingering symptoms that seem to persist once the flare is over? This is the posterior neck of an infant. It looks like a pustular psoriasis who has the deficiency of the interleukin-1 receptor, or known as antagonist or DIRA syndrome. And this is another patient with PAPA, this boy here, who has a PG lesion on his temple. So again, these are patients who definitely might wind up in the derm clinic or with a derm consult. Rashes are across the board. I say rash, and the second I try to tell you one specific rash, I'm a liar. You've already seen a lot of different cutaneous manifestations. This here is actually paniculitis of a young man now who we still don't know what he has, but he has a very pronounced paniculitis as part of his fever syndrome. Do they have lymphadenopathy? And if so, is it localized or is it more generalized? And most of the time when you biopsy these, they're going to be reactive. But a lot of kids have had lymph node biopsies for concern of a malignancy. Do they have serositis, pleuritis, peritonitis, really bad chest pain, abdominal pain, where people do think it's an acute abdomen a lot of the time? Patients often will report that during their flare, they'll have constipation, but they'll know it's going to be over once they start having diarrhea. Oral ulcers, very, very common, as are arthralgias, arthritis, myalgias, myositis. This here is a boy with PAPA, and you can see he's got very puffy looking MTPs. He had an arthritis down in his feet. Other important history, do they have organomegaly? This little girl has massive spleen. We'll see it later. It'll come back to see us again. And they can have any number of ophthalmic findings, from the inflammatory eye disease to conjunctivitis, a periorbital edema. This is a little girl with Dada 2. You can appreciate her periorbital edema there. And it can be just anterior or actually posterior uveitis as well, depending on what they have. This one's kind of interesting because this is why a patient might have a consult to GU. A young boy can have testicular or scrotal pain, and the reason being is the tunica vaginalis is an extension of the abdominal serosa. So much like you can have an acute abdomen appearing, this can look like an acute scrotum sometimes if they have this really acute scrotal attacks. So that could be a reason to get urology involved. Genital ulcers are seen in a number of our diseases as well. You do want to take a good immune and infectious history. A lot of the times you're actually going to hear that these are the healthiest kids on the block who are getting fevers all the time. They'll say compared to their brothers and sisters, they have a much milder cold when they get it. Their classmates get sick. They're not getting sick like that. They're just having these fever episodes that are coming on their own course. There are some of our diseases that can have an overlapping immune deficiency though, so it is good to take a good history. Many of our diseases can have some sensory neural hearing loss, so just asking or paying attention to see if it seems like that might be there. Are there CNS manifestations, strokes, aseptic meningitis, frequent migraines, visual problems that might tip you off towards certain diseases? And then response to vaccinations. Mevalonate kinase disease, or HIDS, actually, these often present when they go for their 2-month, 4-month, 6-month vaccines because they'll get them. And unlike the typical like low-grade fever that babies can get, this sets them off. This triggers their immune system to go into overdrive, and their disease will cause them to get 104, 105 degree flares. They get really, really sick after this. And these are the parents who are like, we're done with vaccines a lot of the time because their kids get so sick when they get vaccines. And have they had their appendix removed, their gallbladder removed, any sort of exploratory surgery? Because it's not uncommon to hear that. And although you can see autoinflammatory disease across the world, there are certain of our diseases that definitely have a predilection to certain ethnicities. So on an exam, hopefully you're seeing the kid and it's going to be benign because you've got them in between a flare, and that happens a lot. And the parents will be so frustrated because they'll be like, "This is not what they look like when they're sick," and you're showing, "Okay, I believe you." But of course, vital signs, looking at their fever, good eye exam, looking to see this is a little boy who had a history of stroke with DADA2. You can see asking him to look up, he can't do so on the left. Again, good looking for the oral ulcers, pharyngitis. Do they have lymphadenopathy, and where is it localized to? Do they have any sort of an acute abdomen finding with rebound tenderness, any arthritis, of course, skin findings? This little girl over here, I'll just mention, she has a disease called SABI, which is mutations in STING, and it involves the peripheral vasculature being destroyed. So that's why she's got the erythema of her tip of her nose and her cheeks and then all of her fingers. And without treatment, this slowly will like cause her fingers to resorb, and it's a really bad disease, but she sure is cute. I can't and really encourage the importance of getting both a set of baseline labs as well as flare labs, because you want to see what they look like at baseline and how it compares, and do they have residual inflammation in between flares. It's very important to see. And then other just routine labs that I've listed here, nothing very out of this world. I always say do evaluate a full autoantibody profile just on the off chance they could have an autoimmune disease, because some of these features definitely do blur with that. And here we have a thalamic stroke in a patient who has DADA2. This here is, remember I was talking about vaccines a couple slides ago. This is a little girl who has that MKD HIDS disease, and she had gotten a series of shots in her thigh. And a couple days later, she got admitted to the ICU, actually in like a SIRS type of event where she required, a lot of pressors and fluids because she had gone so far off the chart. And when we imaged her thighs, we saw that she had this diffuse like myositis fasciitis picture. And then this here is another boy who has a history of Papa syndrome, just again highlighting how cystic in nature these lesions can be. All right. So if you're seeing these and you think, okay, what do I need to do next? I think this might be autoinflammatory disease. Well, thank goodness we live in the genetic era. And if you say, okay, well, this family has a history of this, I know it's a slam dunk, I know I'm going to get it. You can do single gene testing for any of these diseases. But so often their symptoms will be resemble one another. There's overlap, and you really don't know what it could be. And the good news is that there's a lot of these next generation sequence-based panels now that will test like 200 to 300 genes that have been identified to be associated with autoinflammatory and immune dysregulatory diseases. And then sadly, though, we still very often strike out in our pursuit for diagnosis. So the next level would be to do exome or genome sequencing. And if you're considering this, I highly recommend trying to do the trio approach, which is where you would get the parental samples too, to kind of cross match and cross out some of the genes that come back, because they come back with a laundry list of variants. But when you do so, I highly encourage you to make sure you do a very good parental history, because parents, when their kids are sick, are often very stoic and they're not going to report symptoms themselves. But if you look hard enough, a lot of the time you might find that a parent had a lot of fever illnesses when they were young. They had their tonsils taken out, or they actually do still have symptoms, but they're kind of putting it on the back burner because they're so worried about their kid. And if you don't find that out, the way you analyze the results is going to be completely in error, because you're going to miss potential genes. And then we're recognizing more and more that there can be somatic mutations that are causing some of our diseases. So if you've struck out with everything else and you still are saying, I really think something might be there, looking at deep sequencing to look for mutations that might just be in certain cell types is available. But again, I'd like to say that by the end of pursuing all this, you're going to get the answers you seek. But sadly, that is not the case. And when I looked at 553 of our patients at NIH who we did exomes on, we found that 78% of them at the end of the exome sequencing at the analysis, we still had as undiagnosed. 8% had a candidate gene of interest, 8% had a final diagnosis, and 6% we made a clinical diagnosis in. And it's not that the answers aren't there. I just say that sometimes I think our technology is smarter than we are. The answer might be staring us in the face, but if no one has an interest in a specific gene and doesn't know what it does, and it has some like obscure name, I always say like PIG1, nobody's going to say, oh yeah, that PIG1, I think that might be the cause. It's when you amass a number of exomes over time, and all of a sudden you'll get another kid who comes in and has this random PIG1 mutation that you're like, maybe we need to consider this. So it may take a few months, it may take 10 years before you can take someone's results and figure out actually what's going on, make a diagnosis. All right, you've made them wait long enough. We're going to go back to the patients. So we had these frazzled parents with this healthy looking boy. And you go back in to talk to them, you're all up on your autoinflammatory disease. And so I'm going to take a bit more history. And you find that these flares were very cyclical in nature. He would get sore throat and a lot of oral ulcers every time he has these flares. He also gets cervical lymphadenopathy, and there's no family history. And as you are seeing right now, he is completely well in between flares, and the onset was at 2.5 years. And this is where you say, okay, I know this, I think I've got the diagnosis. I think this is PFAPA, the syndrome of periodic fevers with aphthostomatitis, pharyngitis, and cervical adenopathy, which is, again, the most common periodic fever syndrome in children. It is also the most clock-like irregularity of any of the periodic fever syndromes. And these are the parents who know, I'm not scheduling vacation over this week because this is when they get sick. And often these are kids who we say have a very dramatic initial response to corticosteroids. We even joke that sometimes you open up the bottle and wave it under their nose and they start feeling better. But the attacks sadly then start becoming more frequent a lot of the time. And of course, our end goal is not steroids because obviously that comes with its own set of baggage. It can run in families, but there's no Mendelian pattern to it. And generally, these patients outgrow it by adulthood. Their immune systems maybe get more robust where they have much milder symptoms, or it can completely go away. These are patients, too, who are commonly referred to ENT doctors because tonsillectomy and adenoidectomy can be very effective in stopping their flares. Excuse me. But then other times, either the parents don't want them to get a surgery, or they have flares that come back. And so the use of the IL-1 receptor antagonist, anakinra, at the time of flares has been shown to be highly effective sometimes at preventing or getting their flares aborted. About 30% of patients too respond to oral cimetidine, which is interesting because we really don't understand why, but it's worth a shot, especially in parents who are leery of steroids and, of course, shots. So my colleague, this is kind of an interesting story here. My colleague at the NIH, Dr. Kalpana Manthram, came to us about a decade ago and wanted to look at genetic risk variants for PFAPA to see if there were some. So she got all these specimens, seen all these patients over time, and she has found out that there are risk variants near IL-12A, STAT4, IL-10, and CCR1 and CCR3. And okay, so cool. That's great. What does that mean? But then she was at a meeting and she came across a poster from the group of 23andMe. And we've all seen, and heard about 23andMe doing genetic testing. And they ask you a whole laundry list of questions in the kit when you are filling out and getting ready to submit your specimen. And one of the questions they asked is, have you ever had a canker sore? Which seems silly because who really hasn't had a canker sore? But I guess the people who've had more than one were more likely to say yes. And so for people who clicked yes, I have had canker sores, they did a genome-wide association study on these patients, and they found, so this was 180,000 cases roughly, and they did find that, much like Dr. Manthram, there were hits at IL-12A, IL-10, STAT4, and CCR3. So showing that we're taking canker sores and putting it on a spectrum with patients who have PFAPA. And then she took it a step further because it has also been identified in a disease known as Behçet's disease, where you can have oral ulcers, genital ulcers, and some other more severe features, that they all share these risk variants as well. So she has published now on this spectrum of disorders that starts with recurrent aphthous ulcers and extends through PFAPA all the way to Behçet's disease. And so we've kind of linked the very common with the very rare. And this is one of the favorite genetic slides they show, is that this is specific to Behçet's disease, but can be applied to many diseases, is that you can have these very high effect rare alleles that lead to a disease. And one of the examples of this is a disease known as haploinsufficiency of A20, which are mutations in TNF-AIP3, which can cause a Behçet's-like phenotype. But then you have these very low effect sizes as you go down, showing these low frequent and common variants that just have a association with disease. And that's what we're showing with these patients on this spectrum, the IL-10, the STAT4, that these are much more common but can be seen if you look wide enough, 180,000 patients or so, you can see the effect that it has. All right, so you say to those parents, okay, we're going to try steroids. He's never tried steroids. We're going to see what happens, and you send him on his way. And then you're like, I got to go deal with this girl. So you go back into the room of this 15-year-old girl, and you say, I need to take a little more history because I think I know what's going on. And lo and behold, you do know what's going on because she has, again, the hallmark disease, an autoinflammatory disease known as familial Mediterranean fever. It was originally genetically associated with the MEFV gene back in 1997 by Dr. Dan Kastner at the NIH. And these are patients who have these fever flares that will last 24 to 72 hours. The vast majority have fever, and this is a lot, again, where they'll have this sterile peritonitis and pleurisy. They can have the arthritis and arthralgia, and then that specific rash over the ankle, we'll look at it again. And 2% of them, in our diseases, there are patients who can go on to get the dreaded secondary AA amyloidosis due to inflammatory disease. And these are patients who can develop this, so you always want to look for protein in the urine, since testing for serum amyloid A here in the US is not very easy to do. So FMF is an autosomal recessive disease. For the most part, there are a few dominantly associated variants, but in general, it's autosomal recessive caused by 2 mutations in MEFB. And this looks like a lot, and we're going to touch on it here because we're going to see it again in a few other screens. But one of the buzzwords in the autoinflammatory disease world is the word inflammasome. And it's a multi-unit protein structure that comes together. And the end result, when you do so, is you get cleavage of these pro-inflammatory cytokines like IL-1 beta, pro-IL-1 beta, pro-IL-18. It gets cleaved, and then the active forms are released and cause inflammation. Specific to FMF, MEFV encodes for this pyrin protein. And so the pyrin inflammasome is what's involved in FMF. And again, the end result is the conversion and release of active IL-1 and beta and IL-18. Here again is the picture of the erysipeloid erythema, the characteristic FMF rash, and you see it over the dorsum of the foot or the malleolus, and it comes and goes with the flares, and can be quite painful. And how would you treat these patients, though? Well, I'm here to tell you, thank goodness, since 1970 by Dr. Steve Goldfinger, it was recognized that the oral medication colchicine is highly effective in reducing the frequency of flares, the severity of flares, and also one's risk for AA amyloidosis. And most patients do very well on just taking PO colchicine for this disease, but there are some who can't tolerate the colchicine because they get the dreaded GI side effects, or they're not very compliant with their therapy, or they just have more severe disease. And the good news is that there has been a newer drug that was FDA approved for FMF in 2018, and it is the IL-1 beta monoclonal antibody known as canakinumab. And it was published in the New England Journal showing that if you use this, it's a long-acting IL-1 blocker, that it really helps, again, to decrease the frequency, severity, and the risk of AA amyloidosis. So for those who can't tolerate colchicine, this is available. But for this 15-year-old girl, you're like, she's not on colchicine. We're going to start with colchicine. It's not an injection. She can take it every day. And you're like, nailed it. Got her on her way. Now, for those of you who might be a little bit of history buffs, this is a really cool story, I think. The question is when Dr. J. Che and his postdocs were looking at MEFV at the NIH mutations, they started wondering, why is there such a high carrier frequency of MEFV mutations in certain Middle Eastern populations? And when I say high, I'm saying they took the 3 most common FMF mutations and analyzed them and found that they overall in the various ethnic groups had a risk of 10 to 12% carrier frequency. And although that might not seem a lot, the carrier frequency of CF, the most common lethal recessive disorder in North America, is approximately 4%. 4%. This is 10 to 12, so that's a lot. And so they worked with some other groups and put together this beautiful manuscript, which Dr. Kastner likes to say the Faustian bargain of FMF. And going back in time, there was this very bad point in time where we had this pandemic known as the Black Plague. And it was from infections with Yersinia pestis. And what Yersinia pestis does is it releases this virulence factor, YAP-M, into the body. And what YAP-M does, come to know that what we know now, is it inhibits that pyrin inflammasome, which I showed you a couple of slides ago. So it doesn't allow the pyrin inflammasome to fire. It doesn't get that active IL-1 release that can help to fight off an infection. All right, so people are dying because they can't mount in a response to this infection. People with FMF, 2 MEFV mutations, when they looked at them and looked at this YAP-M virulence factor, well, look what it did. It was not able to inhibit the pyrin inflammasome. So these patients with FMF were able to mount a response and had a higher likelihood of living. And then when you looked at the carriers in this area who were being affected, they did find too that just having 1 MEFV mutation still allowed them to mount their pyrin inflammasome response. So these carriers over there were able to mount a response, produce the IL-1 beta that could help them to potentially survive this disease. So in actuality, this is a great example of survival of the fittest, and these were the patients who lived, therefore their carrier rate took it forward, and that's why it is so high. And I think that is a really cool, like, historic history to the present tie-in. All right, so you've dealt with 2 new patients, and now I'm going to tell you kind of what I do, and it's where we see patients who are undifferentiated and try to give them a diagnosis and help them with their diseases. And I call this one A Tale of 2 Little Girls. And this is a little girl who came to the NIH back in the early 2000s. She's obviously not happy to be there. She was 2. She was referred to be evaluated by Dr. Kastner for possible disease known as Muckle-Wells disease. And she had a history of fever, and she had a history of rash, and she had a history of 2 strokes. You can actually see she's got the interning of her left foot here. And you can see she's got this very pronounced rash. And Dr. Kastner looked at her and said, "This is not a Muckle-Wells rash. So you do not have that disease, but I don't know what you have." And so he treated her empirically with the IL-1 receptor antagonist anakinra for the next decade, and she kind of did well, but she had a longstanding sequela as a result of her strokes. But she remained kind of just in the cohort. Fast forward 10 years, I have come along to work there. I am reviewing a chart for the Undiagnosed Disease Network. And I come across a chart of a little girl, 6-year-old little girl from Texas, has a history of fever, has a history of rash. And as you can see here, she kind of got like that mottled appearance too, which fever and rash are very, very common. So that's not what set her apart, but she had a history of 6 strokes. Now, these were the early days of us really getting to send some of our specimens for the exome sequencing. And so, again, like I said, fever and rash, very, very common in our cohort, but pediatric strokes, not at all. So we said, let's send these 2 girls, separated by 10 years here. We send them off, and lo and behold, what comes back is one common gene where they both had 2 mutations in it. And that was the gene ADA2. And we've set about then trying to characterize this disease and find more patients over the course of the next 2 years. We were rewarded in our efforts in 2014 with publication in the New England Journal of early onset stroke and vasculopathy associated with mutations in ADA2. And along the road, though, we'd found some Israeli colleagues who had a cohort of patients who had been diagnosed with polyarteritis nodosa or PAN, who also had mutations. So we had back-to-back publications in that issue. And one might be saying, so this is one of those genes where ADA2, no one would have ever chosen this one in a list until you had 2 patients who had the mutations, because nobody really knew what it was doing. It's not very well known. But we found there's 2 ways to screen for DADA2. One, you can do the genetic testing, looking for the 2 mutations, their loss of function mutations, but also you can do enzymatic testing. Dr. Mike Hirschfield at Duke has been very gracious about doing this for us. And we find that healthy controls have levels of ADA2 enzymatic activity running about here. Carriers are reduced by like a half, and then you can see our DADA2 patients have near absent to virtually undetectable levels of ADA2 enzymatic activity. But again, we said, okay, we know this, we see this, but what is it doing? And we said, well, okay, what is ADA2? We here in the pediatrics world have definitely heard about ADA1 because there's a form of severe combined immune deficiency or SCID that can be due to mutations in ADA1. And so this is the much lesser known sibling of ADA1. And when you compare the 2, you can see there's quite a few differences. ADA2 is a homodimer that's highly glycosylated. It's secreted compared to the intracellular ADA1. It's got a much lower affinity to bind to adenosine compared to ADA1. ADA1 will stick to it like glue, and it's expressed in a lot more different cells. And it was speculated that ADA2 may have growth factor activity. So it's, again, trying to figure out what's going on in these patients with the strokes and the fevers. We took our patients and did biopsies to look at their endothelial cells. And down here in panels D and F, we have controls. And as you can see, their vessels were kind of smooth and ribbon-like. Not a lot going on here, but look at all these patient samples. They have thickened walls. They have disordered walls, looking like there may be breaks here. So not at all smooth like those first 2 controls. And then when we looked for inflammation, here on the bottom CNF, we have the controls. Red is indicative of inflammation. You can see controls, it's all blue, all a cool blue. But you look at these patients and they have this very pronounced perivascular TNF staining. So we said, okay, there is TNF alpha there. We also discovered that the patients with DADA2, ADA2 was important in the promotion of the development of the anti-inflammatory M2 macrophages. So when it's not present, you get overabundance of the inflammatory M1 macrophages. So when you put this all together, we have endothelial cell disruption coupled with inflammatory macrophages that are producing a lot of TNF alpha. And you bring this together with a perfect bad storm, and you have a lot of the inflammatory features of DADA2 that we were seeing. However, it didn't end there, and we're a decade smarter than what we were then, and we have found that what we first thought, all these inflammatory and vascular features, are not at all where DADA2 starts and ends. And we've found that there's a cohort of DADA2 patients who can have a very profound immune dysregulatory, a lot of different immune deficiencies. They've been diagnosed with CVID, they've been diagnosed with hypogam along the way. You can see there can be almost any of their cell lines that have been affected. And then we also started finding out there's patients who have pure red cell aplasia or varying forms of cytopenia, being diagnosed with Evans syndrome or immune-mediated neutropenia. And there are some who have a complete trilineage bone marrow failure who have mutations and have DADA2. But again, not so simple. When we looked at 60 of our patients at the time, we had 60 in our cohort, we found that it's very rare that you have somebody who really manifests just one of these phenotypes. And that, in fact, there's quite a lot of bleeding between it when you look at these patients. And look, 1/3 of our patient cohort at that time actually had all three main phenotypes that we found when we looked at them. So again, this is where I go back to autoinflammatory disease really is multi-specialty, and being aware that it exists, even if you're not a rheumatologist or immunologist, is important, because these DADA2, this is just DADA2 right here. This was put out by Dr. Pui Lee, that you may see them showing up in any of the clinics for these variety of problems, which can also make the identification of this disease quite tough, because it's very hard to spread the word about a disease across medicine as a whole. Again, this becomes a big deal because as we go forward, Dr. Pui Lee, let me tell you about this first. This is where I say my job, I could retire happily, because we saw these patients and they had been tried on just about everything. The kitchen sink included prednisone, Cytoxan, methotrexate, IVIG, rituximab, anakinra, canakinumab, IL-6 blockade with tocilizumab, and they kept having strokes. They might feel better from an inflammatory perspective, but they were having strokes. We saw that TNF production perivascularly and said, these patients haven't really been tried on TNF inhibitors. So in June of 2013, we started putting these patients on TNF inhibitors. And we got reports from the families, oh my gosh, my previously very sedentary child who was very quite content to sit on the couch is now climbing trees and getting in fights with their siblings. What have you done to my child? We said, this is actually good. They're feeling better. But over time, I realized I wasn't getting these panicked emergency room calls in the middle of the night. We have your patient here. They've had a stroke. What do you want us to do? And so we said, we need to look at this. And we did, and in our first 15 patients who had a history of stroke who we would put on TNF inhibitors, we saw that in the 2,077 cumulative patient months before going on anti-TNFs, they had had 55 total strokes. And in the 733 patient months after TNF initiation, they had had 0. This was really what we considered too good to be true. Again, this was so amazing. So this has carried forward. We've done subsequent publication on more patients and more time has passed, and the use of anti-TNF agents in this disease is paramount to reducing one's risk for stroke. And as there's not a genotype-phenotype correlate to be known, I recommend that everybody, even if they have more of a hematologic arm of their disease, be offered at least the option for TNF inhibitors, because in this disease, I say, for all the badness that it can occur, the one thing that can alter one's life in an instant is a bad stroke. And the phenotype can switch on a dime. They can go from being very inflammatory to having complete bone marrow failure. So you can't really predict what's going to happen. Anti-TNFs also help in other ways. This little girl was started in June of 2013, and as you can see, over the course of the next 7 years, she grew and grew and grew and looked a lot more less affected from steroid use. As you can see, she looked completely normal with some mild livido there on her legs. And this was the same little girl who had the whopper of a spleen. And you can see there it was 16 centimeters when she was initiated. And as she grew, it started to shrink. So much so that by the time 2019 came around, her spleen had shrunk to being within the normal limits. And remember that perivascular TNF that we saw. We went back because we said, okay, well, clinically these patients are feeling a lot better, but let's see if we can't prove it a little more. Here are 4 patients. Controls are here on the left. Here are 4 patients before going on anti-TNF. You can see the red again is present there, showing that there's TNF involved. Repeat biopsy on these patients is showing you don't see it anymore. So we are managing to get it to go away from the perivascular region. But I'd love to say that it's a slam dunk and everybody does great, but some features of the disease are not quite so responsive to TNF inhibition. And we recognize that now, and we do know that there are some who we have to send for stem cell transplant. Dr. Hassan Hashem did an analysis of 36 patients who had undergone 45 transplants, with the most common indications being pure red cell aplasia, neutropenia, combination of the two, or pancytopenia. So the bone marrow patients don't seem to really have as much of a response. What we have found, though, is that you need to have very careful consideration to the pre-transplant screening. Pay a lot of attention to the liver, because we were caught off guard with how much the liver can be affected in this disease. And we got burned a few times with the conditioning regimen. It was tough on the liver, or post-transplant as well. So you need to take that in consideration for the conditioning regimen. And of course, there are patients, we've lived and learned, 36 patients, 45 transplants. So there are some who've required second and in some cases even a third transplant until they are finally fully engrafted. And those patients in general are mostly the neutropenia patients, because it seems like some of the host lymphocytes, which are causing the neutropenia, stick around. And if you don't really try to eradicate them, they have a way of coming back and killing off that graft. So lastly, again, you're like, okay, super rare disease. This has all been great. How many people have DADA2 though? Dr. Pui Lee at Boston again did an analysis and found that the carrier rate is really actually 1 in 236 individuals. So think about the number of people who work here in any one day. You've got a number of DADA2 carriers walking around. And he looked at this over a lot of different populations. And you can see the Finnish had the highest at 1 in 160, and Ashkenazi Jewish down at the lowest, but again, overall 1 in 236 individuals. I know. Disease prevalence then was estimated at 1 in 220,000 roughly, which when you take this forward, it would show that there are 30,000 cases worldwide of DADA2. We know of less than 700. We're not doing a very good job. And again, I think it's so hard to make every specialty aware that this disease exists. So I spend a lot of time talking and trying to raise awareness. And I say, once you've seen this disease once, you will recognize it again. Even if it looks different, you will start seeing it. So lastly, we're going to jump for just a few minutes to talk about a disease that was published initially in 2019, where ALPK1 mutations in 5 families led to this disease that the ophthalmology world described as ROSA syndrome. But they didn't really have an associated inflammatory phenotype reported. And so what does ALPK1 do and mutations in it? Well, first off, ROSA stands for retinal dystrophy, optic nerve edema, splenomegaly, anhidrosis, and migraine headaches. So a lot of eye stuff going on here. These are patients who have progressed to being legally blind at a young age. Well, ALPK1 is a novel sensor of 7 carbon sugars, and it kind of goes haywire. And as you can see, mutations have been described here on the ligand binding area. And that's just a fancy looking picture that's showing here how it's figuring in with ALPK1. And Dr. Christina Kozicki at the NIH, we started seeing these patients because initially they were referred to us because some were having periodic fevers. And we found that actually quite a few of these patients had inflammatory features of disease to go along with their other symptoms. So the vast majority have this optic disc elevation, which you can kind of see in the pictures here, the blurring of it. And like I said, a lot are legally blind. A number had non-infectious fevers, and they can also have really big spleens. And as such, sometimes lower blood counts. The dental caries are significant, and they've also been shown to have very small roots. This is normal, this is their roots, so they'll have very poor dentition. Also, they can have anhidrosis, hyperhidrosis, arthritis, and inflammatory arthritis that can go along, and frequent headaches. So what we have found when we analyze is that both transfected and patient fibroblasts showed an upregulation of STAT1 phosphorylation, and you can see this in the top on both of these, that from wild type, which is faint, with the patients who have mutations, the band is getting darker. And here we have the patient fibroblasts as well, showing the darkened STAT1 phosphorylation. And then when we did a heat map, looking at the ROSA patients for interferon-based genes, we found that the patients red means hot, had a lot more red than the healthy controls did over here. And the reason this is important is because we started wondering, well, how can we treat these inflammatory features of disease? And as such, can we do anything to slow this visual progress? And so we tried anti-TNF and we tried anti-IL-1, and the patients felt a lot better. And what we did see is on anti-TNFs, the heat map, here's untreated, here is treated. They went from being nice, hot, and red to resembling very much the healthy controls with the blue. But the visual disease, the ophthalmologic disease, was still progressing. And so what we did see then, once we said, well, let's try IL-6 blockade, and we put them on tocilizumab. And as you can see here, there was this blurring, this optic nerve like elevation and edema that is getting much better post-tocilizumab. And also here, these black areas are the cystic areas on the macular edema. And you can see post-tocilizumab, we've had reduction in that. And actually, we just got notification in a 3-generation family with ROSA that the youngest generation, her mom's big goal for her, as she's legally blind, that her daughter would be able to learn how to drive a car. This little girl just turned 16 and has gotten her permit and is driving, which is a big deal because she came to us with cystic lesions and now has resolved. So a big win for them, and what a nice thing for these families who have had a lot of blindness plague them for years and years and years. So in summary, we've gone all over the place. I hope that you can think autoinflammatory when patients have recurrent febrile episodes with other systemic symptoms that are not explained by infection, autoimmune disease, or malignancy, and that detailed family history is key. And consider genetic testing, candidate gene versus one of those next generation sequencing panels or whole exome genome sequencing. And if you need help, refer to genetics, rheumatology, immunology, infectious disease, who might have seen more of these diseases. It's very institution dependent. And common treatments would be glucocorticoids to kind of get you in the game, and then also trying to target more with cytokine inhibitors. And for certain diseases, colchicine and FMF, or maybe cimetidine and PFAPA exist too. But the take-home message is it can feel like you're on an island alone. Don't worry. Don't get overwhelmed because you are not alone. You will see these patients. I hope your eyes are open to them. And guess what? I am your phone a friend. You can reach out to me at any time. I get so many emails and phone calls every week from all around the world with people saying, I got this patient. Do you have any ideas? And if it's an undifferentiated, oftentimes I really don't have a lot of answers, but sometimes knowing that someone is right there along with you to validate what you're seeing and give you ideas for treatments you might have, I like to do that. So please feel free to reach out to me. And if you don't hear back, very quickly email me again, because I do sometimes get bogged down. And I have a great team at the NIH, which has made some of this all possible. And of course, Dr. Dan Kastner, who is the godfather, grandfather of these diseases, wouldn't have been possible without him taking a chance on me 14 years ago when I was looking to try my hand at clinical research. I have in some your little packets, I put some reference for you. But again, thank you so much for inviting me. It's been a great pleasure to come speak with you, and I'm happy to take any questions.
Thanks very much. And that credit code 33024. And there's one from online. Are there more malignancies in those kids with the tendency?
So overall, we don't see a lot of malignancy. Now, that being said, for DADA2 in particular, the lymphocytes are big bad guys. They're the ones who cause the neutropenia. And for them, there are patients who have had like an LGL leukemia, which one might say is from in their inflammatory disease, or there have been a number who have been diagnosed with Hodgkin's lymphoma. And then there are some other of our diseases, not as prevalent in kids, but a newer one called Vexus syndrome, where many of them have been diagnosed with like a myelodysplastic syndrome along the way. Although when you look at them, generally it's more of an inflammatory type of an MDS. But overall, across the board, it's not like FMF or TRAPS or DADA2 are having lots of cancer. You put your hands up at the exact same time, so choose.
Oh, okay. I was just curious, do you find cytokine panels help you point towards any direction?
I want them to be helpful so very badly. I want them to be, but oftentimes I do not find them all that helpful. IL-18 can be a side note to that, because sometimes, that will be elevated and that can give you various ideas as to a certain pathway. But unfortunately, IL-1 is very finicky to test, and it just seems like we don't capture what we're looking for. Although it's not to say that I don't still try sometimes.
So thanks for the great talk. I'd like to point out on your first slide, I think the ID docs would have recognized both of those very quickly.
And I give you credit too.
I'm curious about the ones that we don't recognize and how recognize. There are a couple phenotypes that we and our rheumatology friends get involved in a lot that really interest us. One is the monoarthritis that always gets anchored to septic arthritis. And the full workup is negative and they don't have a typical rheumatologic disease, but they look autoinflammatory. How might we approach those? The second is even more difficult. Those are the kids who get a viral or bacterial pneumonia and then spend a month in the ICU with severe pulmonary inflammation, sometimes lethal. So it's clearly a dysregulation of the innate immune system of some sort, probably genetically driven. How might we approach those kids?
So first off is that a lot of times, and maybe you have a different experience, but for these patients with the monoarthritis where they're going in, maybe seeing you, seeing then ortho, getting washed out joints, not really healing, having continued, it's oftentimes there's other clues if we can look beyond the immediacy of that joint, that you'll hear something in their past. Like there was something like, oh, the parents are actually able to say maybe they had this rash one time that went unexplained, or other systemic features that go beyond the absolute now. Because I think sometimes we get so focused on now that we miss the fact that, mom's got signs of having like a cystic acne scarring or something like that might point towards. So really, taking a step back from why they're there and trying to figure out, are there additional clues? Because it's very rare that these diseases truly present with just a singular like arthritis joint. There's going to be something else deranged along the way, and then having a low threshold for trying to send for some of these panels, which a lot of them now, we're lucky that even if insurance doesn't cover them, if the parents pay like $250, $300, if they can get that, they can get through some of these companies these genetic panels, which knowing that can be very helpful towards at least getting your foot in the door. And then the second one, as far as the pulmonary and like the viral illness setting it off, it's almost like that was the straw that broke the camel's back, right? They were primed and ready to have something develop. And that's probably that illness, that acute viral illness or bacterial illness is what did it. And it's kind of like with the vaccines and that one disease, all it took was that one final push. And I think you're already on to it though. Once you've seen it and you've seen these patients like this, you can pick up those where you're like, this is not right. Like something is off. And so you're on to it. So you're a step ahead of the game. It's some of these other places where they don't have that. And again, looking to see, were there any clues of anything leading up to this? Had something not been right? Did they walk with a limp for a couple of days and you didn't know why? Or, something that seemed off, and then the family history again. But I think we just need to really support the not needing to delay looking for genetic causes of this, sending these panels. But if you're seeing these kids in the ICU and requiring ventilation and you're like, what's wrong? This shouldn't have been, sending off genetic panels earlier than later, see if you can get any clues.
In that regard, it's kind of interesting that patients who have MyD88 and IRAK4 deficiency had worse COVID.
Yes.
And these patients are generally only get sick when they're young, before their adaptive immunity comes along. They get very bad infections with maybe gram-positive bacteria. So there are precedents for these monogenetic disorders leading to worsened outcomes with viral infections. And we just haven't been looking at them, I think. There is though someone who's very interested in that. He's at the NIH, and I'm blanking on his name, Castellanos, no, that's not his name. Anyway, toll-like receptors, lots of other things.
Yes. I was going to say though, in some ways, for all the bad that COVID did, is that I do think it broadened everyone's idea to the fact that these horrible inflammatory, conditions can come along, and so people are ready. This is the time to talk about these things because I think people are primed and ready to open their minds to the fact that we got to start thinking outside of the box when we see these cases like this, which are having this very it's like viral pneumonia on steroids, like that has gone crazy. The fact that we need to think outside of the box for these rather than just like spinning our wheels doing what we've always done. So I guess thank you, COVID. Your first, Hannah.
I have just a follow-up question from that conversation. So I think we do get a lot of consults on these kids now, which COVID probably has helped raise awareness about this hyperinflammatory response. But I hadn't been thinking about it in the way that you mentioned in terms of thinking of it as the straw that breaks the camel's back. Should we be thinking about these patients as, now that this has happened, if they survive the ICU, if they make it home, should we be following them for autoinflammation?
I think so, or at least planting the seed that, hey, they're better. Thank goodness they're better, but pay very close attention, like giving a broad overview of if you start seeing fevers that don't make sense, or if they're getting a rash that you thought were bug bites, but they're not, they're getting this bruised appearance, or any sort of thing where a parent might be willing to brush things off. Sometimes maybe not if their kids had that kind of thing happen, but I would be really easy to brush this off as such. And in fact, I did. I started this journey at the NIH in 2010, fresh out of fellowship, and was doing autoinflammatory disease. Daughter born in 2010, son born in 2012. Son at 5 months of age started having fevers to 105. I was like, daycare kid. But my husband and I had to miss work a lot, and it was in his 1-year appointment where I was like, he's having fevers every month. Can you please, when you do his blood check, just check a blood count? Make me feel better. I know I'm not supposed to see zebras because I see them all the time. They did profound anemia, platelet count was 600,000. He was supposedly well. I was like, okay, something is wrong. So lo and behold, a small world. We have a kid who has an autoinflammatory disease and has been on the IL-1 beta antagonist canakinumab now for a good number of years and does much, much better. But it's one of those where I brushed it off, feel bad about it now, but he's none the worse for wear and doesn't remember neglectful mother. But I think that again, really planting the seed for these parents to maybe a little more hyper vigilant for looking for things that don't resemble necessarily what they were hospitalized for, but that could still be an inflammatory type of thing. Erin?
Logic manifestations of data too.
Yes.
So I feel like with Evans syndrome, a lot of times as rheumatologists, we're primed to think about the potential for lupus, which you'd never use a TNF for.
Right.
So which, in what cases would make you maybe shift more towards data 2 and doing that ADA testing?
Good question. And so we've had a few who have been diagnosed with Evans along the way. And again, sometimes you'll get that history where, oh yeah, when they were 13, they had fevers for a couple months. We weren't sure what was going on. They got better. Or they once upon a time had this rash. There's a lot of times there's some history. But then again, if you're finding that you're looking for various antibodies and you're not finding them, or in some of our cases, this was a secondary diagnosis. We diagnosed a boy in Chicago who presented with immune-mediated neutropenia and who'd been on transfusions for his red cell aplasia, thought to have Diamond Blackfan since birth, but actually had DADA2. And it was when we were asking, we always ask about the siblings. And they're like, oh yeah, his brother's 22. He's doing really well. He just had this bout of thing when he was 15. It was called Evans syndrome. And we were like, oh no, you need to be tested, and lo and behold, yes, he is positive, although he was, that disease can have quiet periods. And so we caught him at a time and we're like, hey, you've got this. I know you feel well now, but look at your brother, look at what you've actually had in the past. You know, would you like to go on TNF inhibition? And
Uh, does data 2 or does data 2 or A20 have those insufficient to get better as they enter adulthood?
I'd like to say that they do, but I think of it more as these diseases, for the most part, PFAPA is a little different, but for the most part, these diseases can vary from decade to decade. So, you know, they might have a very tumultuous teenage years and then have a very quiet 20s. And then, you know, somewhere down the line again, their disease will flare up. So it's not necessarily they get better in adulthood. It's just maybe they have a different flavor of disease for a period of time. And so always saying that even though they feel well, and it could be okay to go off certain, like I wouldn't recommend necessarily coming off treatment in data 2, knowing that the strokes could happen. But for some of these diseases like FMF, people will have great decades. And if you can prove that their inflammatory markers aren't elevated, and if they want to take a holiday from their colchicine, as long as they get periodic lab work, if they're not feeling well and you know are in tune to the fact that it can come back, I'm okay with that.
Thanks, everybody. Thank you.
Thank you all.